Hello, everyone. I'm Dr. Priyank Patel from the Bombay Spine Society. I would like to welcome everyone to our Bombay Spine Society Case of the Month. This time we have Dr. Nikhil Joshi, a dynamic spine surgeon from Jupiter Hospital, Thane, who practices in and around multiple specialty hospitals around Thane and Dombivli. Over to you, Nikhil, for your case.
Good evening, everybody. Thank you very much, Bombay Spine Society, for this opportunity. There was a 63-year-old gentleman who is a retired rickshaw driver, came to be in my clinic with a deformity in mid-back region since his childhood. He attributes his deformity to his childhood trauma at the age of around 1 year, but no details of any injury or trauma could be found out. There was gradually progressive weakness in both the legs, and his bladder bowel was intact. He was continent, but he was wheelchair bound, and he was able to stand, but he was crawling at home because he could not walk without anybody's support. On examination, he has a classical myelopathic gait, and his sensations were reduced below L2, L3 on both sides. There was a proximal muscle weakness bilaterally in hip flexors, that is L2, 3/5 power, and knee extensors were weak. Distal power was normal in both the legs. Plantars were upgoing. There was no clonus. There was a rounded kyphosis on the dorsolumbar spine. The skin over the kyphosis was normal and it was non-tender. Upper limb neurology was normal. These are the clinical pictures where you can see the deformity in the mid-back region. The deformity was not getting increased on standing or sitting position, and there was no change on lying down in neurological examination. These are the X-rays where we could see that there were fused vertebrae D8, D9, D10, and D11 anteriorly. We can see the pedicles on the posterior aspect, and there were crowding of the ribs at the level of the deformity in the AP X-ray. This is an MRI scan where you can see that the cord is kinked at the lower end of the deformity. You can also observe that the spinal cord is stretched, but there is still a rim of cerebrospinal fluid anterior to it at the apex of the deformity. These are the axial cuts, and this is the area of maximum compression, which you can visualize that the maximum compression is from the sides. This is the dorsolumbar region where you can see that there is an actual adjacent segment disease with buckling of the ligamentum flavum and protrusion of the disc and osteophyte complex, which is causing compression of the spinal cord, and the myelomenistic change at the level below the level of apex of the kyphosis. Now, what next?
So it's an interesting case, right? Because almost always we see such high kyphotic patients, and when they present with myelopathy, in your head you always feel that this is a delayed myelopathy because of cord stretch. But this is an unusual presentation where the cord is not really stretched that much, and the myelopathy is because of compression lower down the kyphosis.
Being a rickshaw driver, he has to bend, he has to sometimes push the rickshaw also. So he could manage all that throughout his career, and there was no problem whatsoever, except that there was a bend in his back.
Correct.
And I completely agree with you that there was no cord compression as such at the level of apex of the deformity. And many of these patients, as per the literature, they come up in the earlier middle age or early young age. And the maximum reason for myelopathy is stretching and thinning of the cord at the apex, and that requires urgent surgery. Many of them are bladder bowel wise incontinent also.
So what did you do for this?
Yes, so initially we wanted to see more and learn about this deformity. So we got his CT scan done. So these are the sagittal and axial cuts of the deformity. And there is actually the vacuum phenomenon at below the level of the apex. So it is actually acting as an adjacent segment disease and unstable spine at that level, which needs attention. So we had these three options in my mind: whether I should do a only decompression laminectomy and take care of that buckled ligamentum flavum, or I should do an in situ fusion, or complete hog like deformity correction using an osteotomy But considering that he had lived this deformity for so long without having any problem, I had to weigh the risk and complications of the full Hoff surgery, including chances of neurodeficit and profuse blood loss, with the current neurological status. So we wanted to give him some solution to his myelopathy and not land up into a good X-ray picture, but having a paraplegic patient. So we discussed with the patient, and according to me, the only reason for his problem was a myelopathy below the level of kyphosis, and hence we decided to tackle that problem only rather than doing complete deformity correction. This is what I did. We fused him in situ. We fused 3 level above and below, so D5 to L2 in situ fusion. We did laminectomy at D11, D12. And at the same time, we approached the D11-12 disc space through a transforaminal approach like a TLIF. And we curated that disc completely. It was an empty space. It was like a completely degenerated disc. So we curated the end plates and we put the autograft which we obtained from the laminectomy. This is the intraoperative picture. On the right side, it's a cranial end. On the left side, it's the caudal end. You can see the laminectomy defect, which is shown by a yellow arrow. And on the blue arrow is suggestive of the transforaminal approach and facetectomy through which we approach the anterior disc space. We did this surgery under neuromonitoring. Preoperatively in supine as well as in prone position, there were very low signals in the lower limb. But as soon as we did flavum excision and laminectomy, we could get some signals in these lower limb muscles, as you can see here in the soleus. And there was no dropping of signals after that. Patient came post-operatively started getting up and walk with the help of support in our neuro rehabilitation unit. And this is a video at 6 months where he is independent and takes very minimal support while walking. He's still under follow-up. It's been 9 months or 10 months since his surgery now. I'm waiting for his 1 year or 1.5 years since surgery when I will be getting his CT scan to check the status of fusion across D11-12.
This is a very unique case that you have presented. Thank you so much for sharing that with us, and also a very unique approach. So I had a couple of questions regarding this. So since we were not gunning for a correction, did you even consider or think of just doing a localized, fusion here and decompression here rather than, taking so many segments into the picture?
We considered that, but the problem was with the localized decompression alone there was a vacuum phenomenon.
Correct.
So that it would have failed, and it would have caused revision again the problem after a few months or a year in a year or so, and that was the problem considering only decompression. At the same time, fusing only at a lower levels or 1 level above below was not an option because it was a fused mass above. And we have to consider it as a for a long segment fixation, because otherwise it will fail. It will not remain like that. And contouring of the rod is also otherwise not possible. With so much of deformity, putting 1 level screw above below will not hold. I just want to make a point here that looking at this case, I strongly believe that not each and every case of deformity, maybe it has scoliosis or kyphosis, needs deformity correction. We have to cater to the patient's requirement and patient's clinical symptomatology, and accordingly we have to decide the plan as each patient and each case is different. And I would like to thank my team, like my co-spine surgeon Dr. Kapil Mohan, who helped me through this case, and the whole anesthesia team including Dr. Chinmay of Jupiter Hospital, which were very well versed with the patient's condition and neuromonitoring, and it really made the case went very well. So I'm very much thankful to them as well. Thank you very much.
Brilliant. Thank you so much, Nikhil.